And at the outset, happy Teachers' Day to everyone, and especially to those who have given me support at all the times during my career of spanning over 20 years now. So I will be presenting presently today that is there diabetes or endocrine dysfunction following acute pancreatitis? At the outset, I will thank Dr. Siddharth and his organizing team for giving me this opportunity to talk, and why it is important to look for pancreatitis and diabetes mellitus, because if you look at the pancreas, the glucose metabolism, the primary organ, again, is the pancreas. If you look at the picture on the right side, you will realize that whenever there is increased glucose, there is either the insulin deficiency or there is resistance. So if there is islet cell dysfunction, there will be increased glucose, and this will form a vicious circle. Another factor you should understand that obesity and hyperlipidemia or dyslipidemia also contributes to this islet cell dysfunction. So if I look at what is presently the diabetes status in acute pancreatitis, the global pooled incidence, as every one of us does know, it's about 34 per 1,000 years. Hyperglycemia traditionally was thought to be a transient during the phase of an acute pancreatitis, and we have been taught like this during our residency times also. But over the time from 2015 to 19, there were two meta-analyses, and they showed that diabetes persists even after the resolution of acute pancreatitis. So this was in 2019, Frontiers of Physiology, that suggested that there is the new onset diabetes is really there and it persists. So what they found is that if you look at the pooled incidence, it is roughly around 25% over a period of 6 months. So further, longer studies are still awaited. The maximum duration which people have followed up is up to 2 years, but beyond that, there is hardly any data. So, based on this, there was this a beautiful paper in the Japanese Society Journal, and what they found that, I will just skip it through, that they looked at 152 patients and they followed them up for about 2 months, and they decide new onset pre-diabetes, which was defined as HbA1c of 5.7 to 6.4, and new onset diabetes as beyond 6.4. And these patients should not have had prior history of diabetes or taking any insulin or OHAs. And what they found that if you look at the cumulative incidence of both pre-diabetes and diabetes, it is close to 40%. If you look at the second panel, this is pre-diabetes, which is much more common. And if you look at the lower panel, the cumulative incidence of diabetes per se, full-fledged diabetes, is roughly around 12% in this subgroup of patients. Based on this data, they defined 3 trajectories of glycemia in the patients with acute pancreatitis. One, who have almost normal HbA1c level, which is normal stable glycemia, they defined it as. And second is moderate stable, where HbA1c is beyond 5.7, but it is not falling into the category of diabetes. And the third one, which is the red color, is the one which is troubling for most of us, is a high increasing glycemic levels. This, I think, we all know that diabetes secondary to pancreatic disorders has been classified as type 3C. And if I look at what are the possible mechanisms whereby we will look into each of them, but the most catchy is the loss of islet cells, and secondly, autoimmunity. Third one is the shared features, which are shared factors, risk factors for both diabetes as well as acute pancreatitis. I will deal with them one by one. Now let's look at the loss of islet cell. If there is an extensive necrosis, there will be a loss of islet cells, and that should lead to pancreatogenic diabetes. But this is a fact. The same trial which I was looking at initially, more than 10% of the patients who did not have necrotizing pancreatitis developed diabetes over a follow-up of 1 period. If I look at the study carefully, the median Apache is 7 with 4 to 9 as as a range. And if you look at the no necrosis, it's almost 90% of the patients did not have necrosis. So concept of alone islet cell loss causing diabetes is difficult to palliate, and that essentially means that we are looking at some other factors. And what are these factors? The second factor we do look at is autoimmunity. If you look at type 1 diabetes, we realize that it is characterized by autoantibodies. Most common is GAG, followed by others. But important part of the type 1 diabetes is that it has a long latent phase. In acute pancreatitis, again, we are looking at latent phase, which is almost minimal. People are developing diabetes within a span of a minute, within a span of a year or so. This is a case report which was only found in the literature. Presence of anti-GAD antibodies leading to diabetes in pancreatitis. So there are other factors. What other factors we are looking at is the most important is a shared risk factor. What is the important to understand that obesity and hypertriglyceridemia both are important risk factors for both diabetes as well as acute pancreatitis. Both independently are associated with increased severity of the pancreatitis, and if they are present before pancreatitis, then there is increased chance of diabetes per se. So this was from the Hungarian Pancreatic Group multiple hits theory which they published. 1435 patients they looked at, and they have defined most of the things as per the routine clinical practice. And this is important to understand that majority of the patients here were the biliary etiology, not the alcohol, because alcohol has a different role in developing the diabetes. What they found was that the obesity increased the risk of biliary etiology by twofold. And if I look at hyperglycemia-induced acute pancreatitis, it is more common with hyperlipidemia. So they proposed this components of metabolic syndrome. If one factor is there, there's hardly any chance for developing the diabetes. 2 factors, 10%, 3 factors, 24%, and if all are present, it's about 66 to 67%. Local and systemic inflammatory response are important because interleukin C, as we see, is important, plays an important role in hyperglycemia. It is difficult for local factor evaluation because pancreatic tissue in acute pancreatitis is difficult to get. This was a nice paper in pancreatology where they looked at almost all the acute markers associated with hyperglycemia, and they found that it's only interleukin 6, none of the other were associated with the development of hyperglycemia. Now, the next most important factor is, I think, the incretin-insulin axis. Why this is important? Because if you look at the OHAs, the oral hypoglycemic drugs, they are the ones which impair the insulin, which act on the insulin-incretin axis, and they improve the beta cell function, resulting in better euglycemia. So, if I look at the insulin-incretin axis, you will find that there will be exocrine insufficiency in 1/3 of the patients over the 3 years period, and there will be altered GIP and GLP, and these are the factors which lead to development of diabetes. Exocrine pancreatic function, if you look at, is 30%, and if we follow it up to 2 years, you will find that these patients are going to develop diabetes. This is important. The patients who have never developed pancreatic insufficiency, the risk of diabetes is up to 5% in acute pancreatitis or overall, but if they have developed, it jumps to 15 to 25% in patients with acute pancreatitis. These are the risk factors which are associated with the pancreatitis. Here, alcohol should not be taken into account because the numbers were very less, but others like recurrent acute pancreatitis or presence of severe acute pancreatitis is one of the risk factors for development of diabetes. Few slides about the management. As you know that there is hardly anything in the pathophysiology. There are less number of clinical articles, more number of reviews, so we have very limited clinical data. 3 aspects are important: prevention, screening, and treatment. Prevention is largely based on the treatment of the acute pancreatitis per se, and management of risk factors. Screening, as of today, there are no guidelines which suggest for the screening of the diabetes, but based on the literature, it is suggested that there should be screening within the first 12 months because 20% will develop glucose disorder over the first 6 months. This is published in Diabetes Care, where they looked at 360 patients with diabetes following acute pancreatitis and 196 following chronic pancreatitis, and they realized that dependence, this is the freedom from insulin. You look at acute pancreatitis and chronic pancreatitis are much less likely to be free from diabetes. Now, the other thing comes as a OHA. Look at the OHA. This is a meta-analysis where only 7 studies they could find on GLP-1 and 4 based on DPP studies. DPPs are like gliptins. And GLP-1, there is hardly any increased risk of pancreatitis, so they can be safely used. If you look at DPP, there is slightly increased risk of acute pancreatitis, although further studies are required for this. So then to summarize, diabetes after index acute pancreatitis is not transient. Up to 1/4 of the patients will land up with the diabetes. Pathophysiology is poorly understood. Even mild acute pancreatitis has approximately 10% of risk of developing diabetes. Screening strategies need refinement, and insulin dependence is much more common. OHAs are to be weighted with side effects. Thank you.